Good morning. Good morning, ladies and gentlemen. My name is Ruwahyuni Ningsih. It's wonderful and precious chance for me to be Master of Ceremony in the Big Hour event, the Visiting Professor Series, and the topic is Epidemiology and Emerging Viral Infection. First of all, let's say thanks to Allah Subhanahu wa Ta'ala who has given us guidance, healthy, happiness, and mercy, so we can attend and participate in this event without any obstacle. Praise and salutation upon our Prophet Muhammad SAW, the best viewer of this universe. In this beautiful moment, I would like to welcome Professor Sailendra Kasaksena, who will be the best speaker at our event today. The Honorable Dr. R.B. Sularto, SHM Hum, Dean of Diponegoro University Postgraduate School. The Honorable Dr. D.R.H. Dwi Sutiningsih MTes, Chair of the Master of Epidemiology Study Program at Diponegoro University. Once again, we thank you for the presence of Mr. and Mrs. Welcome to all participants of the visiting professor. Ladies and gentlemen, before we begin this event, let us pray together by reading Basmalah. Bismillah. May Allah Subhanahu wa Ta'ala make this event beneficial for all of us, and this event can run smoothly and conducively. When this special event, we have several agenda. So allow me to read several sequence of our agenda. The first is opening. The second is singing Indonesia Raya. The third is remark. The fourth is the core event about epidemiology and emerging viral infection. The fifth is discussion. The sixth is quiz and door prize. And the seventh is closing. The second agenda, singing Indonesia Raya. Let's sing Indonesia Raya together. Thank you, Mr. and Mrs. And the next agenda, I immediately invite the Dr. R.B. Sularto, SHM, Dean of Diponegoro University Postgraduate School, give his remark and continue for the opening of the visiting professor. Please welcome Dr. R.B. Sularto, SHM.
Honorable Professor Sailendra K. Saksena, Professor Suharyo, Head Master Degree of Epidemiology, Diponegoro University. Student, ladies and gentlemen, it is my pleasure to welcome everyone to the Studium Generale lecture that held by School of Postgraduate Studies of Diponegoro University on Monday, 29 August 2022. This lecture will delivered by Professor Sailendra K. Saxena from King George Medical University in Lucknow, India. Professor Sailendra K. Saxena will give a lecture with the topic Molecular Epidemiology Perspective on Disease Prevention and Control. The objective of this lecture are: 1, sharing and exchanging idea and discussion on all aspects on human viral infection and developing new predictive. 2, facilitating students to enhance the quality of their knowledge and their research and development on the molecular mechanism studies. Through this lecture, I hope our students could enhance their knowledge and at the end are able to finish their thesis as final step in their studies. I would like to thank to Professor Sailendra K. Saxena for allowing us a chance to a valuable sharing knowledge, and I hope this lecture will improve the quality of postgraduate education, especially in School of Postgraduate Studies, Diponegoro University. And with the permission of our student and participant, I declare to open this podium generally. Thank you.
Thank you very much to the Dean of Diponegoro University Postgraduate School, Dr. R.B. Sularto SHM, for the remarks and for the opening of visiting professor agenda. Let's skip on the next agenda. The core event will be delivered by Professor Sailendra K. Saxena. Before this, let me introduce our best moderate, Professor Dr. Suharyo Hadisaputra, SPPD KPTI Finasim. Professor Dr. Suharyo, Head of Postgraduate Program of Health Polytechnic Semarang, Indonesia. Professor Dr. Suharyo, Professor Emeritus in Medical Faculty at Diponegoro University, and the education, the first medical faculty undergraduate at Diponegoro University in the Semarang city, the second specialist internal medicine at the Medical Faculty Diponegoro University, the third consultant of infectious tropical disease at Medical Faculty Diponegoro University, and the last, Doctor of Medicine at Diponegoro University at the Semarang city. And the position and employment history, the first head of postgraduate program Health Polytechnic Semarang, 2014 until now, and the second vice chief of Association of Indonesia Infectious Disease from 2010 until 2019. The third, chief of Semarang Association Infectious Disease. The fourth, Director of Postgraduate Program at the Diponegoro University, and the last, Chief of Magister Education Postgraduate Diponegoro University 2001 until 2010. The contact person, email Professor Suharyo at prof_haryo@yahoo.co.id, and the address Health Polytechnic of Semarang, Ministry of Health, Tirto Agung Street, Pedalangan, Banyumane, Indonesia. Please welcome Professor SPPD KPTI.
Okay, thank you very much for Master of Ceremony. Before Professor Salindra Sasina give a lecture, I would like to introduce Prof. Salindra Saxena. Professor Salindra Saxena, Vice Dean and Professor at King George Medical University, Lucknow, India. His research interests involve understanding the molecular mechanism of host defense during human viral infection and developing new predictive, preventive, and therapeutic strategy for them using Japanese encephalitis virus, HIV, and emerging viruses as a model via stem cell and cell culture technology. And also, Professor Salindra, his research work has been published in various high impact factor journal, Science, Nature Medicine, with a high number of citation. And then Professor Salindra has received many awards and honors in India and abroad, including various Young Scientist Awards, BPSC India Veteran Award, and Dr. Bose National Award of Department of Biotechnology of Science and Technology India. And also Dr. Saina is fellow of various international society academic, including Royal College of Pathologists, United Kingdom, Royal Society of Medicine, London, Royal Society of Biology, United Kingdom, and then Royal Society of Chemistry, London, and academic of transitional medicine, professional Austria. And then Professor Salindra, he was named global leader in science by the scientists. Also, he an international opinion leader, expert in vaccination of Japanese encephalitis. Okay, this introduce of Professor Salindra. Before Prof. Salindra give lecture, the topic lecture is epidemiology, perspective in prevention and control. Before Professor Salindra give lecture, I will introduce what is epidemiology. I think epidemiology is study of distribution and determinant of health-related state or event in specified population, and the application of the study to control of the problem. The study control of problem, I mean prevention and promotion. Molecular epidemiology is part of the important epidemiology, and this time very important science for tool prevention and control of the disease, including communicable disease and non-communicable disease. Adequate planning and performance of epidemiological component of study is requirement for obtaining reproducible results reflecting molecular mechanism is interest. So molecular epidemiology is very important Yeah, please, Professor
Professor
from
Salindri
the
from
lecture,
the lecture.
molecular
Molecular
epidemiology
epidemiology
disease
perspective and
prevention
disease
and
prevention
control.
and control.
Please, Professor
Please,
Salindra,
Professor
time
Salindra,
is yours.
time is yours.
Yours,
Yours,
please.
please.
Apologies, Professor Dr. Soharyo and Professor Selina K. Saxena. Before start the mentoring, please pull up Mr. and Mrs. to take picture together. Mas Panji, help us to take picture.
Yeah,
Yes.
please, Prof. Salindra Kasina, time yours. Yeah.
So thank you very much for such a nice introduction. It's a good morning from India. I think it's a good afternoon in Indonesia.
Oh,
So
yeah.
it's really a very nice meeting with all of you. I'm really thankful, Professor Soharyo, for such a nice introduction. And as you suggested, today's topic I took for the communicable disease, which is, I think, more vulnerable in the last 2-3 years, that has been COVID-19. So I thought, why not to make the today's day more apt for the control and prevention of this COVID-19. So today's presentation is dedicated to this COVID. I hope you can see my slides.
Yes, please.
Yes. So can you see my slides?
Yes.
Yeah. So as you know, a lot of people are facing problem with coronavirus. It has been a pandemic. In last couple of years, last 2-3 years, the whole world is facing the problem. And now there is a fear that if something like this happens, how we are going to survive, how as an epidemiologist, we can actually curb these kind of infections and so on. So today's lecture is purely based on that how to build a confidence among the people against the pandemic coronavirus disease 2019, that is COVID-19. So I hope some of you might have seen this movie called Three Idiots. It has been delivered in Indonesian language also, one of the very popular movie, where the name of virus has been used for a professor whose name was Viru Sahasrabuddhe. So a lot of people used to say, I don't like viruses. But sometimes what happens when we are working with the viruses, now we see the popularity of this word virus has gone to something which is very popular. You see, if any song becomes popular, we say it's viral. If something goes to the world, people say it's viral. So that's how the word has become. And now even in the computer, we say super virus and computer virus and so on. It simply shows the popularity of the word to the rest of the world, that how people take the viruses, not only in a wrong sense, but also in a positive sense. So if you see, when the name initially started, so we always say that there is no baby book of the names which we have when a new virus comes in. And that is a very, very important part when we people work with the newer viruses. As I am also the member of this International Committee on Taxonomy of Viruses, ICTV, which gives the nomenclature, it has been found that before the name officially was released, a lot of new names came via media and several other websites and social sites and so on. As you see, Wuhan virus, novel coronavirus 2019, COVID-19 virus, pandemic coronavirus, and so on. But the official name of the virus, which has been given by the ICTV, which is the International Committee on the Taxonomy of Virus, is the severe acute respiratory syndrome coronavirus 2, also known as SARS-CoV-2. And this name was actually given by the ICTV based on phylogeny, taxonomy, established practices, formally recognizing the virus as a sister to the earlier SARS-CoV, which we have seen in 2003. And this is how the virus looks in the electron microscopy. So these were the initial pictures when we started working in the end of 2019. Our first publication came in January 2020 itself. So we were in the first group where we have worked on these viruses as soon as we came to know, being the part of the WHO group. Now, if you say that
Okay. Okay, continue.
yeah, my slides are getting, yeah. So
Yeah.
if you say this virus is an infectious disease, coronavirus 19, which is caused by a newly discovered novel coronavirus. A novel coronavirus is a new coronavirus that has not been previously identified, and the virus causing coronavirus disease, that's COVID-19 or SARS-CoV-2, is not the same as the coronaviruses that commonly circulate among humans and causes mild illness like common cold. So one thing very important to understand with this is that the coronaviruses were known to us from 1939 onwards, but they were used to be known in animals, especially in cattle. But what happened in 1963 onwards, we started looking and seeing the cases of human coronaviruses, which were 229E, NL63, OC43, HKU1, and so on. And these, we are not even bothered about the diagnosis because they used to cause very, very mild infection, and most of the infections were self-limiting, and people used to get recovered by themselves. So that was not the case. So even if today, if somebody says is coronavirus positive, we are least concerned about the severity. But if somebody says I'm COVID-19 positive or I'm SARS coronavirus positive, then it is really a concern for us. So that's how we differentiate that which particular type of coronaviruses you are infected with. And one of the very important thing is, as you all have seen, that the patients with COVID-19 are evaluated and cared differently than the patients with the common coronaviruses diagnosis. So this is something which we have to understand. So if you look into the history, there have been various pandemics reported starting from 165 to 180 BC till now. And now you see the Antonian plague has killed around 5 million people. And if you see the plague of Justinian has killed 30 to 50 million people. Later on, bubonic plague has killed 200 million people. Smallpox killed around 56 million. And later on, if you see cholera, yellow fever, even HIV and AIDS, which is still going on, has killed around 25 to 35 million people. And then later on, we came to know Spanish flu, Russian flu, and this was another big one, Spanish flu, that came in 1918 to 1919. And then we had Asian flu, Hong Kong flu, and then we had MERS. Then we recently saw the Ebola in 2014 to 16. We had SARS, which is 2002 to 3. We had very recently this COVID-19. So if you see, and then just before this in 2009 to 10, we had swine flu. So these were the major pandemics which has caused the worst infection in 20th and 21st century. Now, if you see their impact on deaths, then if you see the Black Death or bubonic plague has killed around 200 million people. Smallpox has killed around 56 million people. Spanish flu has killed around 40 to 50 million people. The plague of Justinian has killed around 30 to 50 million people. HIV has killed around 25 to 35 million people. The third plague, which came very recently in 1855, was 12 million people. And then if you see this cholera, Hong Kong, Russian flu, this COVID here is not that big. So that's what we always say, that this has caused a major pandemic, but it was not such a big havoc as we see here in bubonic plague or smallpox or Spanish flu and so on. I'll tell you a little more detail in the epidemiology section that why I'm saying this. So if you look into the
Okay.
yeah, I'm just waiting for the slide change. Yeah, so if you see, the case fatality rate for Ebola was around 40.4%. For Nipah, it was 77.6%. For SARS, it was around 99.6%. For MERS, it was 34.4%. And for COVID-19, it was just 3.9%. So considering this, the COVID-19 was not that severe as you see Ebola and the MERS were. So this is something which you also have to understand. A disease might be severe, a disease might be pandemic, but maybe the case fatality is low. And that is also one of the important reasons for the world to understand that how to actually handle when these kind of fatalities we see in the patients. So if you see how many types of novel coronavirus we know, there are three types of the originally strains for coronavirus called A, B, and C. The type A is the virus which is closest to the coronavirus found in bats and pangolins, and this is considered the root of the outbreak. One of our recent paper, which is going to come this month from the Journal of Medical Virology, that has shown that how the virus actually originated, and then it changes to type B virus, where there's a variation of coronavirus most common in Wuhan, and this is derived from type A virus, and there are two mutations from the parent virus, and these mutate slowly in China but rapidly outside, which has gone to various Southeast Asian countries like Singapore and several others. And this B virus changes to subtype C virus, and that is the daughter of type B. There's one mutation different from the parent virus. It is spread to the Europe via Singapore, and that has caused the major havoc. Now, if you see these viruses, A virus has changed to the B virus, and there were the two more lineages, A.1, which has gone to Seattle and became extinct. We had another lineage that's called Uganda, and that has gone to 823.1, and this is partly resistant to the antibodies which we developed. That has also been reported in Liverpool. The B virus has gone to Europe, and it has gone to B1 lineage, and now you see that we are having Omicron. These are all B lineage viruses. There's a mutation D614G becomes fixed, raising viral transmissibility. And that's why there's a lot of newer strains in United States, South Africa, California, New York, and then later on in Britain, Denmark, Kent, and then several other places like Brazil and Australia, they have been reported. And wherever you are seeing the full red circle means they are quite resistant to the available vaccine, and wherever you are seeing the half, it means they are partly resistant to the available vaccines. So if you see, there is a mutation in this original spike protein at 484 GAA, and that has changed to another mutation called AAA at the same position in E484K. So this was the original mutated virus from SARS-CoV to SARS-CoV-2 or the COVID-19 virus. But later on, what happened, that once you have seen this, there are three major lineages have gone. One is the B117, or also known as VOC, that is the variant of concern 2020-12 divided by 01. The South Africa lineages which is 501.V2. This 2 has a large number of changes, including in the spike protein. And then there's the Wells lineage, which is known as the Wells 501Y variant. And this virus too has the spike protein mutation. Its lineage 2 is distinct from the B117 and does not include some of the same changes. This variant has been around the UK Wells since autumn but has not spread rapidly. Now, once this sequencing has been done, they have all clustered separately, suggesting that the virus is still mutating. Now, what happens? What is the basic difference in the seasonal influenza and the pandemic COVID-19? As you see, the seasonal influenza occurs every year, whereas pandemic COVID-19 occurs rarely. Only 3 coronavirus outbreaks have been reported in 21st century. As you know, in 2002 and 3, we had SARS-CoV. In 2012, we had MERS. And 2020, we had COVID-19. Now, in seasonal influenza, this type of flu, people are accustomed so that they usually have some immunity built up from the previous exposure, whereas in pandemics, there's no one has any immunity. So everybody who gets the disease, they might get sick. Now, seasonal influenza, the healthy adults don't get the serious complication, whereas in pandemic COVID-19, even the healthy people can get. In seasonal influenza, the vaccine is available. For pandemic COVID-19, when initially it came, there was no vaccine available, and we are still trying to change the vaccine as per the available strains, and every time there's a need to give the vaccine as early as possible, depending upon the circulation of the XYZ newer strains of the SARS-CoV-2. Now, based on this, how this virus looks like, that is a very important question. So these were some of the original work which we have done. And if you see, this is the virus in the indirect immunofluorescence methodology. And here you can see this is one of the T cells in the green color, and this blue is the matured virion, which you can see getting out of the cell via egress process. So there is an envelope outside, which you can see there are the very clear-cut spike glycoproteins on the surface. Then there is a matrix. Then there is a hemagglutinin envelope, RNA and protein inside. And this pipe-like structure has the E protein here, and inside there is an RNA in this. So that's RNA is protected actually. And then there is a E protein, which is the envelope protein. So SARS is actually related to the coronaviruses from the subgenus Cercovirus, and that belongs to a genus called beta coronavirus genus under the coronaviridae family. And that's how these viruses are enveloped, usually rounded, but can be filamentous, composed of a protein-studded coat that surrounds the genome. So this corona means this rays of sun. So you can see it purely looks like a sun-like structure, and that's why they are known as coronavirus. Now, if you see, we have solved this spike glycoprotein structure in much more detail with the help of biophysical technique, and we published this work in the Virus Disease Journal in 2020 January itself. Now, if you see, this is the membrane glycoprotein, then there is a envelope protein, then there's a RNA, which you can see here in a thread-like structure. And these circles which you are seeing is actually the nucleoprotein which protects that DNA and RNA inside. And then these are the spike glycoproteins, which you can see here in a 3D format. So that's how the virus looks like. This structure was given by us even before we got the electron structure in 2020. So this is the genome of the virus, and the genome has around 25 to 32 kb, 25,000 to 30,000 kb genome, and this has three ORFs, ORF1A, ORF1B, and then ORF3A. Besides this, it has five more ORF. They are known as ORF6, 7, 8, 9, 10, and so on. And then these structures make the different proteins, specifically the non-structural proteins, the two viral cysteine proteases, including papain-like proteases, which is coded by NSP3, chymotrypsin-like, 3C-like, or main protease like NSP5, RNA-dependent RNA polymerase NSP12, helicase like NSP13, and other likely to be involved in the transcription and replication of the virus. In addition to NSPs, the genome encodes for the four major structural proteins, like you can see S protein, M protein, and E protein. And that's how the genome is 26 to 32 kb, comprising of 6 to 11 ORFs, encoding 9,680 amino acid protein. Now, if you see the origin and evolution of the human coronaviruses, there have been a lot of theories available. As you know, the coronaviruses were known to us in some or other format. All of them have been originated in via bat. In SARS-CoV was with back and pangolins, whereas the MERS was originated where the intermediate host was camels, and then it has gone to human transmission. But for this virus, we still not know what was the intermediate host. People have suggested bats, people have suggested fishes, snakes, goat, monkey, lemurs, horses, rabbit, pigs, jackals, monkeys, and so on and so forth. So the SARS-CoV-2 has been suggested to have originated from a seafood market in Wuhan, where the wildlife is allegedly killed and the people are exposed to the infection as soon as they cut the meat of those infected. So these can be foodborne or the close contact. We still do not know the cause, but we believe that there is a theory of laboratory leakage has the less weightage than the genetic origin of the virus. Now, if you see, when we have sequenced the virus, so you can see these are the two Wuhan isolates which we have sequenced from the seafood market. We have also done this isolate is from bat, and this is the isolate from bat-like SARS coronavirus. And these are the human viruses came from civet, and these are the isolates from the civet itself. And then we have taken Japanese encephalitis virus, which is found in Asia as an outgroup, just to make sure that there is no lab contamination when we are doing the sequencing. Now, based on this, what we have found that this sequencing data was having around 80 to 90% similarity, except a few points in earlier nCoV, which we have seen in 2019, and then which we have seen in 2003, and in 2019, what we have seen among this around 80 to 90% similarity was there. Not only that, so this was one of the previous structures. This was one of the previous structures which we have given. So this is the spike protein, and this is the RBD domain, which was a complex structure. We have solved it with the help of the biophysics. Now, if you see, this is the virus, which I have explained in the previous picture. There was a glycan receptor. So that's how the virus attaches with the host cell membrane. And then this whole process, when the glycan receptors bind with the virus with those host cell surface for glycolysis, and then this is actually helped with the help of viral surface glycoprotein, and glycosylation of the viral surface glycoprotein actually helps the virus to internalize. This knowledge which we initiated actually helped us to find out the monoclonal antibodies which can block so that the virus cannot get in. We also have been understanding the glycosylation of the viral surface envelope, and we also did the GBPs on the host cell surface so that these things can help in response favoring host antigen presentation or response favoring viral attachment and entry, and that's how the host cell surface actually helps the virus to get in. Now, if you see, these are the sites which we have seen. So this is the new virus 2019, and you can see this is the old virus which we have seen in 2003. So these were the places where you see the square, they were the same sites, but where we do not see the square, these are the newer sites. So that means the virus was knowing that how to enter inside the cell. What is the significance of the glycosylation and these glycosylation sites? These are just like identity cards. So when you go to your university, you wear the identity card, and based on the identity card, you have been given access to attend the class. But somebody who mischiefs, who might be a terrorist, he uses that card and pretends that he is that person whose card it is, but actually he is not that person. So if he knows all these entry points, he will use that card and he can misuse it so that it can enter inside the cell. And that's what has happened with the T cell. So that's why the T cell cannot recognize that it's a foreign material, and they allowed the virus to get in. So it's one of the very important strategy when viruses invade our immune system, they play. So this is very, very important to understand that how this glycosylation actually helps. So if we have to develop a vaccine, we actually have to consider these sites. So we did that, and based on that, we found these were the monoclonal antibody sites in 2019, and these were in SARS-CoV-2. There were only very, very few sites which were same. So considering this, we tried to use the earlier available treatment modalities as well as the vaccines which we were having for SARS-CoV to be used for the SARS-CoV-2. And based on this, what we have done is that we have suggested a couple of medicines, including Fabiflu and so on, which became later on one of the standard part of the treatment, including SCQ and so on, we have done. So that eventually came into the mainstream and has been approved by the FDA for the human users, and they have been used worldwide for this. So I really feel happy that some of the work which we have done has saved the lives of the people in a gross level. Now, if you see, this is the way the virus looks like, and this is the earlier known virus, and this is the 2003 virus. Now, when we have, in spite of more than 10% difference, when we have merged the virus or superimposed the viruses on each other, we haven't found any significant difference in the spike glycoprotein. This simply shows that although the virus was different, but it pretended not only just like you, but it has used the mask of yours also, so that even in the iCard also the photo matches with your face. So that's how they allowed, the T cells allowed the cell to come in, and that's how the virus has actually taken into the consideration of the T cells. So collectively, for the first time, our data has suggested the emergence of the human SARS-CoV-2, or also known as 2019 nCoV, which was closely related to the predecessor SARS-CoV. We have also shown that there are the novel glycosylation sites as SARS-CoV-2 and may have a potential to become pandemic owing to its antigenic discrepancy we have also suggested demonstration of novel CTL epitopes, and that may impart opportunities for the development of peptide-based vaccination. Eventually, the two vaccines, Covishield and Covaxin, which came from India, and you might have seen that all which we have done on the work behind this actually has been translated. And then the similarity in the spike glycoprotein structure suggests that the coronavirus specific attachment inhibitors might work, and that's how the Fabiflu became the drug of choice. So this all work got published at very early stage during 2020. So later on, if you see the epidemiology of the disease, in December 31st, 2019, the China alerted WHO for the several cases of pneumonia with no known cause in the Wuhan. The disease goes on to be named as COVID-19. Jan 7, WHO officials announced they have identified a new virus named SARS-CoV-2 that causes COVID-19. It belongs to a coronavirus family, which includes viruses like SARS, MERS, and common cold. Jan 11, China announced the first death linked to COVID-19. Jan 13, WHO reported the first case of outside China, that's in Thailand. In February 26, the NIH begins the first clinical trial using the remdesivir. On February 29, the FDA took steps to expand the novel coronavirus testing to the hospital, clinical microbiology laboratories. March 11, WHO declared COVID-19 as pandemic. And we have said this thing on January itself. And then it has more than 100,000 cases by that time, and more than 4,000 people have died in 114 countries. Confirmed cases of COVID-19 top more than 1 million worldwide by April 2. And since then, the disease is global, we all know. And you see how the world has actually taken care of. Now, if you see the international travel during December 2019 to February 2020, it was although quite significant, but not that significant that it can cause a pandemic. You can see a couple of the part of the world was actually not yet touched. And if you see the picture of February to April 2020, you see the whole world was infected. Wherever we were not seeing the infection, that area was also having the infection. And that's why it was very important for us to understand that how big role in these infections the international travel has had. Now, if you see till date on August 25th, the latest data which we have, the worldwide around 599 million cases have been reported with 6.48 million deaths. Whereas if you see in the Indonesia itself, 6.33 million cases with around 157,000 cases of deaths have been reported. Now, if you see later on, there have been the knowledge which we are getting from the various pandemics, and that is the first wave, second wave, and the third wave. And that's how, if you see this, this is called the first wave, where we have seen, and based on this, we predicted the several waves in COVID-19 also. And in various countries, we had first wave, second wave, third wave, fourth wave, fifth wave, and so on. Now, if you see, these are the top 20 countries around the world which are having the highest number of cases. You can see the USA is still tops the list with a significant number of active cases are more than 33,14,152. whereas in India it is 84,931 cases. And here, if you can see in the bottom, Indonesia, that is around 6,34,304 cases. And now if you see the per million cases, if in the Indonesia, it is coming to 22,686 cases per million. And if you see the deaths, that also you see it's 563. So that's how we can always say that Indonesia is doing much better than several other countries whose mortality was higher. You can see Brazil, Germany, UK. You see the mortality is much, much, much higher than the Indonesia. So this is something we have to understand, that how these things can be taken care of into the future. Now, if you see, in most of the cases, 63.33 were discharged, 2.55 were dead, and there were around 34.12 were active cases. Whereas by age, if you see, at least in India, most of the cases were in the age group of 20 to 49, because this was the age group which was shaking hands, meeting outside, going and doing things. 25% cases were in the age group of 50 to 70, and 11% cases were 0 to 19. So that's how this is by age. 3/4 of the cases were in males, again by shaking hands, and only 24% was, or 1/4 was in the females. Now, if you say further that how the virus replicates, these are the RNA viruses, have one of the very complicated process of replication. And at that time in 2019-20, nothing was known. And this was the picture drawn by us. That is still one of the important picture that how this virus replicates. So this is the virus, as I have showed you earlier. And then this virus actually gets attached with the help of ACE2 receptor. And then there's an uncoating happens. And this is the viral RNA that gets free. And this viral RNA is actually inside. So that's how this viral RNA which gets out, and then there's a replication and translation happens of this in making the various ORFs and the proteins. This all goes for translation, and then it goes to the rough ER, and then goes to the processing in the endoplasmic reticulum, goes to the assembly and budding with the help of Golgi, then goes and then makes a vesicle outside. Then exocytosis happens and the virus gets released. So that's how this virus actually replicates. It's a very, very complicated process for the synthesis of the virus from within the cell. Now, how this virus is transmitted? We all know now that the virus is transmitted via two things: droplet containing the virus in the air, or droplets which fall onto the surface, and if we touch that, any of this happens. So droplet containing virus in the air is the droplets land in nose, mouth, possibly lungs. And once these people go into the society, you can see here, they infect the whole society with the virus. So that's how this transmission happens. And virus is transmitted primarily through large particle respiratory droplet. This requires close contact between the source and the recipient person. Contact with contaminated surface is another possible source. All respiratory secretions and body fluids are treated as one of the infectious material. Now, these are some of the very, very common ways from where we can get the infections: doorknobs, common telephones, and so on. The children's have a little longer time of infection, beginning 1 day prior the onset of the disease and up to the 14 days or more when they become sick. That means that you may be able to pass on the COVID-19 to someone else before you know that you are sick, especially from children. So that's why it is very important that if children are sick, you have to be more cautious that they do not develop symptoms early, and that's why they can pass on the disease to the others. Now, these are some of the activities by which the virus transmits. So we should not do this. We have to have a little distance from the people. These are some of the activities they should not be done so that the virus should not transmit, including, you see, hugging and cuddling with your kids if they are not well. So how this virus that causes the disease, that is called pathogenesis. So when somebody sneezes and coughs in front of your nose, then the virus goes inside your nose, and then it goes to trachea, and then it goes to bronchus, and then bronchioles, and then settles into alveolar macrophages. Here it starts producing the alveolar um, this mucilage, and then it also inflames the bronchial lymph node. And based on this, once this mucilage and this starts, when somebody starts coughing and sneezing, then these goes to alveola, bronchioles, bronchus, and so on. And that's how the virus gets to the different parts of the body. Now, if you see, when somebody gets SARS-CoV-2 infection, there is a humoral immune response and there is a cellular immune response. So if you are well, you do not have any problem, then cellular immune response, which is actually causing the protection from any infection when you get, so dendritic cells catch, and then they put the virus to the T cell with the help of TCR, T cell receptor, and this binds, and this is called activated T cell or also TH cell. This gets the message to the CD4 cells, that is called effector cell, and then immediately starts producing cytokine and chemokine. And based on this starts killing the virus, and this passes the message to the activated cytotoxic T cell, also known as CD8 cells, and they send a message to CTR effector cells, and that's how the killing of the infected cell happens. And this eventually sends the message to the B cell so that they make an antibody, and they also know that the virus can be, again, if the same virus comes in, then they keep the message. But if the virus is mutating, you might get the infection again and again, and that's what is happening with SARS-CoV-2. But these antibodies which you get from the previous site of infection, they are sufficient enough to viral elimination, and at least you don't get the severe infection as it is happening now. Now, what are the symptoms of the COVID-19? We all know the symptoms, but before that, we should know the incubation period. The estimated incubation period is unknown, and it ranges from 2 to 14 days. Later on, we started saying 10 days, but actually it is 2 to 14 days. The infectious period is the exact duration of shedding with the SARS-CoV-2 virus is unknown. The estimated duration of viral shedding is based upon infection. In general, persons with COVID-19 virus infection should be considered potentially infectious from 1 day before to 12 days following the illness of the onset. So this is something which we have to follow when we are doing a clinical practice. Now, most of the patients which were coming, around 80% of the patients were having a very, very mild infection. 13% had severe and 6% had the critical infection. The mild were having simply fever, fatigue, and dry cough. The severe were having fever, fatigue, dry cough with aches and pains, running nose, sore throat, shortness of breath, and diarrhea. And the critical were having multi-organ failure in addition to these symptoms, and they used to come to the hospital very late, and that's why the mortality which I showed you earlier, 3.9%, was because of those critical cases. Most of these cases were having some or other type of comorbidity situation, like for example, they might be having diabetes, hypertension, and several other infections, which we know that they might have the cause of death. So if you see, as I said, that the incubation period is 2 to 14 days, the median is around 5 days, and most patients will be in this phase and do not progress into pneumonia phase. And normally they get recovered from day. So if you see, they have fever, cough, sore throat, arthralgia, myalgia, GI tract problems like abdominal, diarrhea, vomiting, and pain. Whereas if they progress from here to pneumonia, then the condition is severe. It is called fever, lethargy. There is a C-reactive protein goes up, the liver parameters goes down. CXR features of pneumonia starts coming in the chest, X-ray, and then hypoxia or progressive exertional dyspnea starts happening, shortness of breath starts happening. A lot of people who are having the long COVID, they are also having this kind of problems now, and these factors starts going up, and ALC and SpO2 starts going down. The clinical deterioration happens, and the nasopharyngeal replication binding to H2 receptor happens in lungs and liver. And day 8 and day 10, the hydroxychloroquine can be given. If progressive, then lopinavir and ritonavir can also be given. And if the clinical condition deteriorates, then we also give hydroxychloroquine with lopinavir and ritonavir. But if still we are unable to handle this situation, or if the doctor is not good, or if the patient is coming to us very late, then there might be shock, there can be acute respiratory distress, and then multi-organ failure. And that's the place where the patient mostly dies. And at this is the most mortality in this phase. Cytokine storm starts getting up, interleukins in Th2 gets, significantly up. And these are the couple of medicines other than the earlier which I said. We also have ribavirin, interferon beta, and immunomodulators like steroids, IVIG, and tocilizumab is one of the things which we have used during this kind of problem. So people have to understand this chart was also made by us and has been very, very widely used for understanding of COVID-19, clinical progression, and the proposed management, not only in India, but several other countries. So very important, and this is also available in the book which we have published. So how to know when to go to the doctor? This is a very, very important question. So when in the children, if you want to know, there should be breathlessness. There should be cyanosis. That means the skin color becomes blue. They are not drinking enough fluids, not waking up, not interacting, being so irritable that the child does not want to be held. Flu-like symptoms improve, but then return with fever and worse cough, fever with rash. So these are the couple of things where the children can be monitored. In adults, if you see, they have the difficult breathing and shortness of breath, pain or pressure in the chest or abdomen, sudden dizziness, confusion. Confusion is always associated with when some infection is there in the brain, severe or persistent vomiting. This means that the virus has gone or crossed the blood-brain barrier, and that's how you start getting the vomiting. So whenever you start getting fever with vomiting, please do not take it lightly. Always meet to your physician as early as possible. Now, if you see, a lot of people used to say it's a common cold, and it's just that the doctors are making money and there is nothing called COVID-19. But any expert doctor can tell you whether you are suffering with common cold or flu, or whether you have allergies, and whether there's a COVID-19. And based on this classification, we can differentiate that you see that how the COVID-19 is different from the common cold, flu, and allergies. Now, if you see what were the complications, where people who died, what were the problems? You see, most of the patients were having upper respiratory tract disease, sinusitis, otitis media, lower respiratory tract diseases like pneumonia, bronchiolitis, status asthmaticus, where the asthma starts coming up, cardiac myocarditis, pericarditis, musculoskeletal myositis, rhabdomyolysis, neurological encephalopathy, acute and post-infectious encephalitis, febrile seizures, status epilepticus, toxic shock syndrome, secondary bacterial pneumonia with or without sepsis. Now, if you see what are the high risk for complications, or who are the people who are at the high risk? Children less than 5 years, and the persons who are more than 65 years or older, they are at high risk. Children and adolescents who are on aspirin therapy. Aspirin is very dangerous and should not be used without the proper prescription. At least in COVID, it is completely contraindicated because it increases the chances of Ray's syndrome. If you take this, the multi-organ failure can happen. Pregnant women are at the high risk. Adults and children with chronic pulmonary, cardiovascular, hepatic, hematological, neurological, neuromuscular, or metabolic disorders are at high risk. Adults and children who have immunosuppression, like for example, the patients who are infected with HIV, HBV, HCV, and so on, where the immunosuppression can happen. Residents of nursing homes and chronic care facilities, because they are exposed with the patients almost every day. So they are also at the risk of the infection. Now, how we diagnose the virus? We have couple of case definitions which are made by us and then approved by the WHO. So there is a suspected case that a patient with acute respiratory illness with no other etiology and fully explains the clinical presentation and a history of travel to or a resident in a country or area or territory where the COVID-19 cases have been reported in last 14 days, or a patient with any acute respiratory illness having been in contact with a confirmed case in last 14 days, or a patient with severe acute respiratory infection and requiring hospitalization and with no other etiology that fully explains the clinical presentation. So these are the suspected cases. A probable case is where a suspected case for whom testing for COVID-19 is inconclusive, a suspect case for whom testing could not be performed for any other reason, and whereas the confirmed cases where you can see that a person is confirmed with the help of RT-PCR, and once that is done, a laboratory confirmation has been done, then it is irrespective of the clinical sign and symptoms, whether you are suspected or probable, you will be treated as confirmed case. Now, these are the couple of things which we use when we collect the, so this is for the nasal swab and this is for the throat swab. And in this kind of a structure, we collect the virus transmission media. And this is very important because the analytical sensitivity of an assay depends on the specimen type as well as the timing of the specimen collection. If these two things are not correct, you might get a false negative, but actually you are a positive, and vice versa. You might get a false positive, but actually you are negative. So both the way, it is very important that you have to have, these are the very good quality nasal and throat swab things are available. Now, what we collect? So from an ambulatory patient means a patient who can come to my clinic or to the OPD, outpatient department, and can go home. So from an ambulatory patient, we collect nasal swab, throat swab, and we also send it into the virus transmission media. From the intubated patients, which is admitted in the hospital, we collect the lower respiratory aspirate, and from the others, we collect the posterior pharyngeal swab, nasal washes, acute and convalescent serum. This we collect in addition to the above two samples. So that's how we know that what report we are going to give. Now, what is the treatment and antiretroviral agent? So if you see, there is no specific cure yet. Scientists across the world are working to find out the cure and create vaccine and drugs. If you see the worldwide, the people are working on the treatment goal. There are so many preclinical 30 plus in developments. There are several, these 30 plus are in phase 1 and 2, phase 2. In phase 3, there are around 4. Then there are around 5 in phase 5. And phase 4, it is just 1. And that's how they are. Similarly, there are around 41 vaccine candidates, and there are out of that 3 DNA candidates, 1 inactivated, 1 live attenuated, 5 non-replicating viral vectors, 15 subunit, 5 unknown are there, 1 VLP virus-like particles, 7 RNA-based vaccine, and 3 replicating viral vectors. So that's how these 41 vaccine candidate and around 31 preclinical and clinical treatment modalities are in process. Now, if you see, besides this, we have serum therapy, where we take the passive serum from the people who are infected and try to use in a healthy volunteer. In the other sick members where the condition is sick, we have monoclonal antibody therapy, we have adaptive immunotherapy, we have developed the mesenchymal stromal cells, which can actually bind and block the replication of these infected cells. We have nanomedicine, we have decoy biomolecules, and of course, lopinavir, ribavirin, and favipiravir, which is also known as Faviflu. They are already in the market. Now, if you see, most of these molecules which are used for the therapeutic strategies are baricitinib, umifinovir, camostrate. These are the attachment inhibitors. Then at the level of uncoating and the RNA level, we have lopinavir, darunavir, atazanavir, saquinavir. And then once this is synthesizing or RNA replication happens, then remdesivir, favipiravir, or ribavirin is there. Then we also have various subgenomic transcription stages where we have several other molecules. And at the level of maturation, we have oseltamivir, amantadine, and so on. So the virus should not get mature. So these are the various strategies which we are using for killing the virus as soon as we come to know that someone is positive. Besides this, what we do in the hospital, we give a lot of IV fluids so that the virus concentration goes down, parenteral nutrition, oxygen therapy and ventilatory support, very, very important, antibiotics for secondary infection, vasopressor for shock, paracetamol is prescribed for fever, myalgia, and headache. Patients are advised to drink plenty of fluids so that the virus is diluted, and once you pass on the urine, the virus gets out. Avoid smoking because this makes immunocompromised. Short course of topical detergent, saline nasal drops, throat lozenges, and steam inhalation is beneficial. IV fluid, parenteral nutrition. Can you hear me?
Yeah. It's okay.
Yeah. So IV fluids, parenteral nutrition, oxygen therapy, or ventilatory support, Antibiotics for secondary infection, prophylactic should be avoided. Vasopressor for shock. We have paracetamol is prescribed for fever and myalgia. Patients are advised to drink plenty of fluids, because when you drink plenty of fluid, we actually make the virus diluted and it passes through urine. Avoid smoking, it makes you immunocompromised. For sore throat, short course of topical decongestant, saline nasal drops, throat lozenges, and steam inhalation is beneficial. Salicylates and aspirin is strictly contraindicated in any COVID-19 patient due to its potential to cause the Ray's syndrome. Monitor for clinical and radiological evidence of lower respiratory tract infection and for hypoxia. Now, it means that when there's no specific drug and the vaccines are also not completely sure and safe, the prevention is the only thing in our hand. And what we should do, there are the vaccines using mask, washing of hand with soap and water, and keeping at least 6 feet distance, which is the most important preventive strategies. Now, in India, when the vaccine starts coming up, the people were asking, what do you have? And we always used to see we have vaccine in our hand. Mere paas vaccine hai, that means we have the vaccine. So now we have different types of vaccine. We have the virus based, the whole virus as a vaccine, nucleic acid based. We have viral vector based and the protein based. And based on this, we have Covishield and we have Covaxin. These two type of vaccines in India, and I'm sure the similar kind of vaccines are available in your country. And now if you see, there are different vaccines which are going to come: Covishield, Covaxin, J-CoV-D, Sputnik V, and VX-CoV2373, recombinant protein antigen-based vaccine, mRNA-based vaccine, and inactivated rabies vector platform vaccine by Bharat Biotech in the various stages of preclinical trial. Now, this is the sum of the work which we have done, where we have shown the interaction of the consensus epitope with MHC class 1 and 2. And based on this, couple of vaccines have been made. They are already in the market, and we are still doing work for newer strains, so that also will come very soon in the market. Now, this is the multi-epitope vaccine candidate which we have shown at that time. And this was actually helping to counter the infection at a very, very early stage. Now, a lot of people were saying that why should we take a vaccine? Even after vaccination, a lot of people were getting the infection. So this is one of the person who have been vaccinated, but also got the infection. So you can see, this is the lung, CT scans of the lung, and wherever you are seeing this spider's web, they are the signs of the infection. So this fellow had been vaccinated, and in spite of the vaccination, he got the infection. Several of you might have got that also. So a lot of people were having doubts on the vaccination, that whether we should take vaccine or not. Now I'm going to show you a picture of a person who has not taken the vaccine and got infected. This person took the vaccine, got infection. Now you see, this is the picture of a person who has not taken the vaccine and got infected. And unfortunately, we could not save this person. So most of the fatality came because of this, the people who have not taken vaccine. So there has been a huge vaccine hesitancy, and we are always telling the people that please take the vaccine as early as possible, so that you do not have to have this kind of situation. So you can see, this is the with vaccination, without vaccination. So that's how your lung becomes. And once the lungs are gone, we cannot save you. So the vaccine hesitancy has become more common worldwide, and has been cited by the WHO as top 10 global health threat in 2019. The vaccine hesitancy presents a major obstacle to achieving the vaccination coverage that is broad enough to result in the herd immunity, and the public perception that corners are being cut with regard to the safety assessment, and the misinformation about the SARS-CoV-2 infection and the vaccine is another very important reason behind the vaccine hesitancy. If you see here, the factors that affect the COVID-19 vaccine hesitancy is, one is the efficacy. A lot of people have different types of opinion, the concerns about the approval process, sources of information from where they are getting. If you are just believing onto the word of mouth from somebody, they might give you wrong, or the WhatsApp or social media, they are not the correct way of information. So you have to get the correct information from the correct people like us. Demographics, like on average, older people, Black people, and women less willing to be vaccinated. But if you see here, most of the vaccines are FDA approved. There has been very less vaccines which has been given the emergency use authorization. So very important for us to understand that how to tell the people about the vaccine hesitancy. So if you see the China and Brazil and India, most of the countries have taken very high level of vaccines, and I'm sure the same way in your country also people are taking the vaccine. Now, some of the things which I want to tell about the vaccine is that so this blue is the dose 1 and this is the dose 2. Most of the patients had some small pain, which always happens with any injection, fatigue, headache, muscle pain, fever, joint pain, chills, nausea, and swelling. That's it. Nothing significant came other than this, which has been playing any role. So this is very important for us to understand, and that all the myths about the vaccination is not correct. Now, so what we should do? We should cover our mouth and nose with handkerchief or tissue while coughing or sneezing. Wash your hands every time after coughing or sneezing thoroughly with soap and water before and after touching your nose, eyes, and mouth. Avoid crowded places. Stay at home if infected with flu-like illness. Keep at least an arm's distance from people affected with symptoms of flu like cough, running nose, sneezing, and fever. Sleep well, stay physically active, and effectively manage your stress. Because if you are stressed, then again you will get immunocompromised. Then drink plenty of water and eat nutritious food that we always suggest the people who are having the infection. What you should not do not shake hands, hug, or kiss socially, or use other contact greetings. Do not take medicines without consulting the physician. Don't spit outdoor. Do not smoke, and do not use aspirin in children because it causes the chances of race syndrome. Now, you see, putting your mask is one of the best precaution. Washing of your hands is very important. And you might have seen one ad saying, is your soap is slow? But that's not the case. Because earlier what was happening, we used to wash our hands for 60 seconds. Now with the newer soaps like Dettol and Lifebuoy, we can wash the hands in just 30 seconds. And we always say that washing of your hands with soap and water for 30 seconds twice is one of the best precautions, whatever infection you are touching up. When soap and water are not available, use alcohol-based disposable hand wipes or gel sanitizers. But when soap and water is not available, if that is available, use soap and water, wash your hands for 30 seconds. Nothing is better than that. And if using gel, rub your hands until the gel is dry. The gel doesn't need water to work. The alcohol in it kills the germs on your hand. So that's how the infection can be prevented. Now, these are certain strategies which I always tell. You can always try with me. So how this 30 seconds are counted? Just put the soap on your hand. So this is this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 30, 21, 22, 23, 25, 26, 27, 28, 29, and 30. So that's how the hand should be washed. How many of us are doing this? So this is a very, very important hand precaution which everybody has to do. And this has to be done twice, that each and every part of your hand and fingers up to this area needs to be cleaned. So prevention has three important things: prevention in humans, prevention of transmission to humans, and prevention of its spread among the humans. And that's how we always say how to bring this graph to be more plateau, so more flattening of the curve can be achieved. So what we can do, what a common man can do, there's a 4P strategy: plan, prepare, prevent, and protect, and be healthy. So how to plan? Take time to plan that who is the vulnerable population in and around where you live, where you study, who are the family and community members who might get the disease, whether you have enough opportunity at your work and business places to handle the infection. And same thing, you have to plan whether you have enough opportunities at your school, university, and child care place where the enough precautions have been taken care so that your children should not get infection when they are going to these places. Now prepare. You should know the caring for self, family, and community is very important. So make sure that you know that what medication has to be taken, health supplies from where you are going to get, the school closing arrangements are in place, alternative child care arrangements are in place if at the place where your kids are going, if somebody is infected. Now prevent, vaccinate against the disease. This is one of the healthy habits to reduce the risk of infection and illness. Cover your cough. If you do not have something, you have to have this posture where you can cover. If you have any chronic disease, then prevent, like asthma and something, or TB, where if you have, please take care. And washing of your hands with soap and water is the best precaution always. And the protect, that's responding to the COVID-19 to reduce the risk of exposure. So you should know the symptoms, as I said, how to see in children, how to see in adults, know when to see the doctor. You should know how to protect the vulnerable population and breastfeed your baby even when you are sick, because you pass on the antibodies from you to your baby. So it's very, very important to understand. A lot of people have myth that if I'm not well, I will not feed my baby. That's not true. So with this, I came to the end of my talk, and this is just for a lighter mode. It was really a very good interaction with all of you. That as we create more and more, demos means people. So once we create the demos educated, then the panic goes down. If more and more demos in epidemiology means demos is, so if we have the demos means people, if they are educated, then the panic goes down. So the panic automatically, if the demos is there, the panic goes down. And this is one of the number in India. I'm sure the similar kind of numbers are available in your country, where you can call and get all the kind of relief. And this is an infection when we normally don't see in our hands. They are, if somebody is infected, how it looks like in infrared light. And this is just on a lighter note that these are the newly approved greetings from the State Department of Health. It's better not to shake hands. So what you can do the long distance wave. And if there are two professors, they can do the elbow bump. If still you are really willing to shake hands, then wear sanitary gloves. A professor or HOD with the junior faculty can have like this, and two HODs and the deans can do like this, the bump. So this is just on a lighter note. And we are talking about the human infections, but you might have heard we have seen newer infections in animals in zoo and several other parts, especially with SARS-CoV-2. So are we ready for another pandemic? Still, are we there at somewhere? We will talk in the next presentation. And thank you very much for giving me this opportunity to present the work which I have done and our group is doing is still. And this is world's first book written by us. I am sure you might have seen this book. It is freely available on my site. You can download it. Otherwise, if you want to buy, you can buy it from the Amazon and several other places. This book has also been selected for one of the best books to be read in 2021 and 2022 by the Book Authority USA. So no challenge is too big, no problem too complex. This is what inspires us. And thank you once again for giving me the opportunity.
Yeah. Okay. Thank you, Professor Salindra. The excellent lecture about coronavirus, especially of the COVID-19. The audience want to find of your slide, I think. Can you give us the PowerPoint and here to copy your PPT, I think?
I will give you the whole book.
Oh, yeah, the whole book and slide and slide also.
Yes.
Yeah, maybe many question, but maybe I would like to question one question about the molecular epidemiology method of principal control of chronic diseases. Coronavirus consists of the many activity such as vaccination, environment control, vector control, treatment, and mass drug administration. What your opinion about the comment of the control relation of the molecular epidemiology? What's the comment about the molecular epidemiology for prevention of the coronavirus? I think, please, yeah.
It's a very important question. And if you have seen one of my slides where I have shown type A, type B, and type C, they are purely based on the molecular epidemiology. As you see at the 478 position, the GAA has been changed to AAA. So all those classifications which you are seeing, the Omicron or BA1, BA2, BA3, BA4, and all those lineages is actually with the help of molecular epidemiology. So the phylogenetics and the sequencing data is actually helping us to understand that how to proceed with the molecular epidemiology. Not only with that, we have recent, the reproductive value is RO is around 0.68, whereas initially you see we have shown around 3.98. So it has gone down significantly, almost just 10% now. So these are all the work which we are doing, and once I'll send you the book, it's all given in that.
Okay. There's many questions at the in the chat. I think this after presentation participant or question. This yeah. The discussion, I think. Okay. this one, Majid Barangkaya, we know that we know from Mighty, we know that every disease has a cure, but of course it must be followed by hard work, effort to end it. Sailendra's section have our effort of preventing and handling COVID-19 been running expected. Such prevention effort on the form of vaccination, community environment, involvement, COVID-19 prevention effort, and the role of the government is to support this effort. Thank you. What your comment of this question?
Yes, of course. One of the very important thing once this kind of infection comes in, the role of government, and without the government support, it is very difficult for us to handle these kind of infections. So all those hospitals, the free vaccination, at least in our country, making all those approvals at the place as early as possible. So these are the couple of things has happened, and that could not have been possible without the government support. So this was really, really important. And it's not just the government support, even at the international level, the intergovernmental support is also very, very important among the different countries. And you see now we are sitting in India and talking to you that how to handle the disease, and worldwide this has happened. So during this, COVID has taught us that how to actually use the knowledge from the various parts of India so that the infection can be controlled as early as possible. And I personally feel this is really a very, very good step that we have learned because of the COVID.
Okay. And then the question, what future mechanism have your research put into place for the identification of the active sites, glycoprotein, to inhibit the mutation of these viruses to avoid the development of further strains, particularly at the molecular level? What do your opinion this question?
See, this is the RNA viruses, and RNA viruses do not have a proofreading mechanism. So there is no way you can stop the mutation. The mutations will keep on happening, and that's why the newer strains will keep on coming. Now, the only thing is how we can actually handle it. So what we are doing is we are using the regular sequencing. So normally, if you see, there was a slide where sequencing per million, in every country, we are taking the sample of the sequence, sample of the cases which have been positive, and the sequencing is routinely done worldwide, globally. Then we match it and we try to find out if there is any emergence of newer strain. And once these newer strains are considered, they are really new, then based on that, the new vaccines or treatments have been made. So that's how these diseases have been actually handled at the various levels in the, not only in our country, but worldwide, in the global level.
Okay. And then the other question from Rosa Faridila. We know that there are possibility between COVID-19 with unknown etiology of hepatitis. My question, what is the relation between COVID-19 with the other type of hepatitis, such as hepatitis B? Any relation of the COVID-19 hepatitis? What your opinion? Yeah.
So normally there is no way that a good physician will be confused among the COVID-19 and the hepatitis. But yes, it is very important that the people who are having the hepatitis B or so on, they are already immunocompromised. So they should be a little more careful about catching up the COVID-19. They should be away, they should take all the preventive strategies, they should be vaccinated, and they should not get the infection. That's the only thing for the hepatitis patients.
Maybe directly, not relation, but indirect, I think. Okay, Shalindra.
Yes. Yeah. Indirectly, that's what I'm saying. If somebody is having hepatitis B, then of course they have to be taken care of.
And then the other question at the end from Dambi Saiti, if a single change of G and codon GEE to give EEE affecting the amino acid being produced, does it also significantly lead to change the behavior of the virus and subsequently the way it affects a human? And it's so how best the two with achieve herd immunity against COVID-19? Does it also call for continuous reach vaccine development about the vaccine?
So what I have
yeah.
given you that example was just one of the mutation. There are several mutations like this, as you might have seen in our the data which we have shown. So this GAA moving to AAA is just one mutation, making you understand that how the original mutation have appeared from A to B and B to C. But the later on now we have millions of mutations known because of this RNA viruses. And that's why it is very important for us that the regular sequencing of these samples has to be done. And we are already doing at the international level. There's an international alliance which does this under the WHO and several other agencies. And we are not only just the part of that, but we are also helping that how we can help let the people well in advance in the different countries, at least the physicians and the people who are involved in this, that how to actually handle these mutations and whether those mutations are available in that country, then whether will they have any impact on the herd immunity, and if yes, they have an impact, then whether the booster has to be given in that country or not, and if the booster is available for that particular mutation. If not, then we are trying to make it and trying to give to that particular country as early as possible.
And then, okay, the question continue. The group COVID-19 patient take a very high for having obstructed on child and adult chronic lung disorder such as tuberculosis. If yes, how was the COVID-19 and Mycobacterium tuberculosis work attack the body, especially lung, to patient of in bad shape vessel as whole system the treatment? If we can consume herbal medicine and how with the complication with monkeypox, type 2 monkeypox, I think please.
It's a really very complicated question. They have added a lot of things, of things in this. Yes, the people who have tuberculosis, they have a higher chance of comorbidity in COVID-19. And of course, if they develop monkeypox, normally there is something called super infection prevention. Once you have one infection, you normally do not get another viral infection that easily. But even if you get, because that is a RNA virus, monkeypox is a DNA virus. So even if you get, then chances of your survival is of course very, very low. So taking the herbal medicine, of course, people have shown the curcumin and the several other medicines from the herbal medicine have playing a very, very important role. So there's no harm in taking the herbal medicine if they have been tested in your country and approved by your health department.
And maybe you a question again about stem cell. Many clinicians give the treatment of the COVID-19. What opinion, Professor Salendra, about stem cell treatment in here?
See, stem cell treatment has been very, very costly. It is not easily accessible, and getting the autologous cell is again not that easy, because we might get the mesenchymal stem cells from the patients, but these cells are also infected. So it is not that easy for us to actually manage it. So as a technique wise, it is really a good one. But frankly telling you, even I work with the stem cells, it was very difficult for us to make these cells easily so that we can use them actually for the treatment or in the clinical trials.
Have you any research in your institution about stem cell in treatment of COVID-19, Prof?
Yes, we do have,
Mm.
but as I said, it was not that easy for us to do the RCTs or any clinical trial at that level.
Mm. And then the next question. Now, a certain country are giving second booster of COVID-19 vaccine. What do you think will be the long-term solution to have herd immunity in people instead of giving many booster? Like in Indonesia, this time maybe vaccination for time, I think. Yeah, the first, second, and booster one and booster second. What do you think about many times vaccine?
See, I can understand the concerns of the people when the boosters are given. But if you
Yeah.
see, during our childhood, we have been given several vaccines. And have you had any side effects of those? So they have already been considered while making these vaccines. At large, the knowledge which we have, but still, if any untoward situation happens at the latter stage, no one can predict. But deliberately, nothing has been done. The objective is very clear that we want to save you as early, as easily, as successfully as possible. So do not get hesitated. These all things are done not only by just one government or in your country. Everywhere in the world, we are trying to save the people. And that's why we are actually suggesting the people to take the boosters.
Okay, thanks. Any question for audience? Question again, I think. Yuni, any question? No. Okay. If not a question again, we close of this lecture. This, yeah, Prof. D. Any question in here?
Any question, bro?
Yeah. If any question, I think, and so Professor Salendra have a lecture of COVID-19 history, and then causes, transmission, pathogenesis, clinical manifestation, prevention, and vaccination, I think. So very clear, I think, about COVID-19 and Indonesia. I think COVID-19 is still here, I think. So I stop of this visiting lecture. Thank you, Prof. Salendra,
Thank you
of
very much.
the lecture. Thank you very much.
Thank you.
Please, yeah.
Thank you very much to our professor, Professor Sailendra K. Saxena and Professor Dr. Suharyo Hadisaputro, who will give us knowledge. May it will be useful for our life. Amin, amin, ya rabbal alamin. And before we close the event, please the participant all of for the open the camera for take picture together. Please all participate for open the camera.
Okay.
And please Mas Panji for the take picture.
One, two, three. Okay.
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 Oh,
Yes.
yeah.
Thank you very much, Professor Sailendra K. Saxena and Professor Dr. Suharyo Hadisaputra. And the next agenda is door prize. And the door prize giving to 6 participants are number 1 Majidi Nur, number 2 Paradila Rosa, number 3 Eva Fitriani, number 4 Sande, Mr. Sande, dan number 5 Tambi Saidi, and number 6 Narsis Musafili. After this, the commit will be the contact you for the giving the prize. And the second agenda is closing and prayer together. To close the program, let's recite Hamdalah together. Alhamdulillahirabbil alamin. Finally, from the depths of my heart, I do apologize for my mistake in presenting this event. Thank you very much for your kind attention, and thank you very much. Good afternoon.
Good afternoon.
Good afternoon.
Thank you,
Yeah.
Prof. Shailendra.
Thank you,
Prof.
Shalindra.
Haryo.
Yeah.
Thank you.
Thank you.
I will
Thank
contact
you.
you later, Prof. Shailendra.
Yeah.
Thank you. Thank you.